Good afternoon, everyone, and welcome to today's Public Health Ontario Rounds presentation on modeling measles outbreaks in Canada. My name's Kevin Brown, and I'm a scientist at Public Health Ontario. I teach infectious disease epidemiology at the Dalla Lana School of Public Health in Toronto, and I have the pleasure of moderating today's session that will be presented by Caroline Colgin. Before we begin, I'll mention a few housekeeping items. The chat pod has been disabled to limit distractions during the presentation, but you can use the Q&A pod if you have questions during the session. And that's open right now, so you can plug in questions in there as we go. There'll be a discussion and question period that'll follow the presentation, and we'll make every effort to address as many questions as we can. We've got a pretty full house today with over 600 registrants, so we might not be able to get to every single question, but please put your comments in the Q&A pod. If you're experiencing technical issues, you can email capacitybuilding@oahpp.ca during the session. I'd like to state that as the moderator of this session, I don't have any conflicts of interest related to this work. And without further ado, I'll just introduce the presenter. So it's really my pleasure to introduce Dr. Caroline Colgin. Dr. Caroline Colgin is a professor at Simon Fraser University in Burnaby, and she holds a Canada 150 research chair in the mathematics for evolution, infection, and public health. Her work is really at the interface of math and epidemiology of evolution of pathogens. I first met Caroline actually here, well, not actually just now, but in a Zoom meeting, and it was through the auspices of the Ontario Science Table that Peter Uni was heading up in conjunction with Brian Schwartz during the COVID-19 pandemic. And Caroline really provided some really incredible insights on vaccination strategies, on COVID-19 vaccination strategies, and a lot of her work revolved around prioritizing people at higher risk of infection. And some of those insights were adapted and built into Ontario's hotspot vaccination strategy. Caroline also has a longstanding interest in the dynamics of diverse interacting pathogens, work that she's done in conjunction with Mark Lipsitch at Harvard, among others. For example, how does the interplay between co-infection, competition, and selection drive the development of antimicrobial resistance? To answer some of these questions, her group builds new approaches to analyzing genomic data with ecological and epidemiologic principles in mind. So without further ado, I will pass the mic to Caroline.
Thanks so much, and great to be here, and thank you all for coming. I'm going to describe, as it says here, a brief modeling study about potential measles outbreaks in Canada and what they might look like. So I'll just get going. Here's the learning objectives. You can read them here. I'll just pause briefly so people can read them if they want, but I'm not going to read them out. Okay, good. All right, so I'll get into some background. As you probably know, measles has been considered eliminated in Canada since 1998. But it is rising globally, and in particular, I think the EU had around 30,000 cases in 2023 compared to 900 cases in previous years, so a huge expansion in the number of reported measles cases in Europe, and also outbreaks in many other parts of the world. And there have been occasional measles outbreaks in Canada, some of which you're probably more knowledgeable about than I am. But in particular, a large outbreak in Quebec in 2011, over 400 cases in a very under-vaccinated community in BC in 2014, and of course, other sporadic and smaller outbreaks. And that happens not because measles is spreading here in Canada, but because as measles is spreading in other parts of the world, people can come back to Canada and measles gets introduced. And then if it lands in a population that is more susceptible, then of course it can spread. Measles is incredibly infectious, with a basic reproduction number around up to 20, commonly cited as sort of 12 to 18, and that's depends on the population and what people are doing. But it spreads in the air. It can linger in the air for about 2 hours after someone leaves a room, so it's very challenging to control, and that causes considerable effort and cost. Overall, Canada has a high measles vaccination coverage of around 90% on average. And that, data can be a little bit patchy, and there was some impact of the COVID-19 pandemic. But overall, it's very good. And that's, of course, supports measles continuing to be eliminated, being eliminated since 1998. But there are areas and communities that have a much lower vaccination and lower immunity coverage for measles. There we go. So here's some information about that vaccination variability, and of course there's caveats with data of all kinds, but in particular, if you look at the Vancouver School Board, which is on the right, you can see that coverage ranges from actually very low, and maybe those are, who knows whether that's completely correct, to really usually it's quite high in Vancouver schools. It's not 95% for most schools. It's not even above 90% for most schools. So it really does, there's quite a few schools where coverage is below, say, 75 or 80% in here. And those children, of course, are vulnerable to measles. They get measles, they spread measles easily, and it could really spread in a school with a 50 or 70% coverage. Similarly, this is Alberta, and these are different regions, not different schools. There's different geographic regions. And again, you see MMR dose 1 by age 2 is pretty high in the 80%, I guess, or in the 80 to 100% for this part of, I hope you can see my mouse, this part of the histogram. But then there's really quite a lot of regions in Alberta where coverage is quite a bit lower. Saskatchewan, this reported data, it's very high. So there's variability between provinces, between regions within a province, and here between schools, even within a region within a province. So there's variability at all kinds of scales. So the measles was hitting the news recently, a couple of months ago in February, I guess, and that got me thinking about and I knew about these data. I knew about the Vancouver School Board data and variability for COVID vaccination and variability for other childhood vaccination uptake. And we started wondering, given that variability in coverage in Canadian jurisdictions, what can we, and given we know how to do modeling, we have models for measles, what could we say about, if measles does get introduced into Canadian jurisdictions, what might outbreaks look like? How large might they be? How does the potential outbreak size change with different vaccination coverage? So what's the outbreak size likely to be in a school or small population with 70% coverage versus 80% versus 90%? And then how strong do interventions have to be in order to control outbreaks in those lower vaccination settings? So how quickly would we need to find cases, or what would we need to be doing? How do those outbreak sizes depend on parameters that reflect somewhat what public health can do? Okay, so that's the aims. And here's a description of the model. So mathematical models are as well as, in this case, simulations you can run in your computer that synthesize data on how infectious the disease is, how it spreads, what the population size is, how long things take, how long does it take to get rash, who's infectious when. So putting all that information together into a simulation that you can run and then say, okay, given all these assumptions, what happens as we go forward in time? So our model has 4 compartments. All models, I should say, are simplifications of the world. You can't put in all of the complexity that you're interested in, and we have to use judgment and experience and state-of-the-art tools to choose how to simplify the world. So we have 4 compartments. We have people who are susceptible. They're not immune. They're not infected, but they're in the population. So they're in the community that is likely to be exposed as the outbreak progresses. We have people who are infected, but they don't have rash yet. And most of that time they're not infectious yet, but infectiousness begins in our model around 4 days before the onset of rash. And then, so it's 10 days of infection. Okay, that's actually, I changed that to 14 days. But anyway, there's some time period between infection and rash. Then we have a compartment for people who are infected and they have a rash, and they're infectious for 4 days after they get their rash. And then after that, they become immune, and that immunity is great and permanent for the purposes of these, 60 to 90 to 100 day simulations that we're running. We're not running, demographics over decades. So they're recovered. And then if they're vaccinated and they've had their MMR and so on, they're considered to be protected. So they're already in that immune compartment when the simulation starts. Okay, we look at 2 community sizes, and this is one of the challenges of modeling here, because of course Canada has this really high overall vaccination rate, and we know that measles, when it's introduced, doesn't just spread across the whole country, and that's because it's eliminated, and we know we have good enough immunity. So what we're really modeling here is communities that are fairly close knit and are kind of like vulnerable pockets or under protected, under vaccinated pockets in the broader community. So we model 2 sizes, about 1,000, which is sort of a school, maybe a few hundred people, plus close contacts, close household contacts that are really kind of very close knit in a small pocket. And then we also model a larger 8,000 person community, and that comes from an outbreak in Minnesota, where they estimated actually the number of people who had ever been, in contact with a case throughout the whole outbreak. So people who might have been exposed was about 8,000. So also tight knit kind of pocket with a similar vaccination coverage, but a bit broader community. Okay, so that describes the model. And feel free to interrupt if there are questions. Maybe I'll pause there in case there are questions at this point. Okay. Great. So then that's the basic model for what measles is going to do. I mean, we need to also model what we're going to do. So if we're, having vaccination rates above 95%, then what happens is you drop measles into the population, the simulated population, and nothing really happens. Maybe one other person might get infected, but it's not really sustained. But if vaccination rates are lower, we might need interventions. And the main ones we've put in the model are post-exposure prophylaxis, or PEP, and that's MMR vaccine or immunoglobulin offered to people shortly after exposure. It's a bit of a challenge because you need to find them very soon after they've been exposed. I think it's within 3 days for MMR or within 6 days for the immunoglobulin. We also model case finding and isolation for non-immunized people who've been exposed. So maybe not fully isolated, but maybe they're asked not to attend a school or healthcare setting if they're not vaccinated and there's measles around. So people basically leave the susceptible compartment and go into a not contacting others compartment for a few weeks. And then we ask infectious people who have a rash are asked to isolate them and can do so effectively. So these are the kind of the 3 interventions that are in the model. Okay, I'm going to talk a bit about parameters. So when you simulate measles or anything else in a mathematical model, you need to choose numbers that describe how much of these interventions you have, how effective they are, and also the basic natural history parameters for the infection. So here we've used a basic reproduction number of 15, which is bang in the middle of the 12 to 18 range. And that's the average number of new cases, new infections that an infection will produce in the absence of previous exposure or vaccination, so fully susceptible population. Of course, with vaccination, you have that people won't infect 15 others on average, because many of the others they would contact are protected. Okay, we have a 10 to 14 day duration of the exposed class. And that's consistent with 7 to 18 days from the WHO. Infectiousness prior to rash, we model the people who are infected but don't have their rash yet as infectious, but only about 1/3 as much as the people who do have their rash. And that's because most of the time they're exposed, they're not actually infectious yet. They're sort of infectious pre-rash. And then the rash compartment lasts 4 days. Then for interventions, we model people moving out of the class where they're infected pre-rash into a recovered class at a rate. We model people leaving the susceptible class. So they're notified they may have been exposed to measles, and they're asked to either take PEP or just go home and avoid the setting if they're not immune and they can't or won't take PEP because the timing didn't work or they don't want to. And then we ask symptomatic individuals to isolate, and they do that effectively. So that's the people who have a rash, you've got measles, like stay home, don't go to school, don't go out. Okay. I think I have some more information about it, how we chose those parameters here. So we looked at kind of, I think this is a challenge for modeling. It's a simple model of the world, and so we don't really have like individuals and contact tracing teams and calls and who's calling and how many days it takes, and it's not an individual based model, and that and other things complicate the relationship between what public health measures can do and how we translate that into the model. So given that we know that that's uncertain, we picked kind of stronger interventions and weaker interventions. And the main difference is the time it takes to find and notify people who've been exposed. So in the stronger mode, it's about 2 days, we could say 2 or 3 days to find people. And then more than half of them are willing to reduce their contact. And they do that with 35% effectiveness. And that's reflecting that, maybe they stay home, but there are people in their household, or maybe they don't go into a log cabin in the woods where there are 0 other people anywhere around with respiratory contact with them. They do significantly decrease their contact. And then people who are offered PEP, somewhat fewer accept it than isolate. So but I don't really, that's very hard to get out of public outbreak data. But that's from a Minnesota outbreak in 2017. And then within a very short time, half a day or a day of seeing a rash, individuals who have the rash are able to isolate with high effectiveness. And then in the weaker interventions, it takes a bit longer to find people, and that's the main difference. But PEP is offered less because fewer people, if it takes 4 to 5 days to find them, the chance that you find them within 6 days of their exposure is just lower. So that intervention is less. And then maybe people are a bit less aware to watch because it's less spreading and there's less kind of strong messaging. Maybe people are a bit less aware, so it takes them a bit longer between seeing rash and fully isolating. So that's one or 2 days instead of half a day or 1 day. Yeah, Kevin.
We just had a question in the chat about how you parameterized or how you examined persons that were vaccinated in terms of 1 dose or 2 doses.
Yeah, we just modeled a fraction of the population that's protected. So if you know what fraction have 1 dose or 2 dose in a particular school, and the effectiveness of single versus complete, the 1 or 2 doses, then you could work out, whether that school lands in the 70% or 80% bin for how many are protected. Also, the protection, we've kind of modeled it as a percent coverage, but some of it might come from previous measles exposure too, if there's an unvaccinated community. So yeah, we just model kind of a percent protected and how that percent is, how a community arrives at that percent via previous exposure or single or 2 doses as sort of community specific. Okay. So, all right, this is a table that I included for when I sent the slides to people, but I'm not going to read out all those numbers. Okay, the other challenge with modeling, you can set up a model and you can think, oh, this model is going to be great. It's going to do all these realistic things. And then it can surprise you. So it's really important to see what happens in the model and is that realistic? It's hard, it's a stochastic model. We don't know what's going to happen. Usually when an infectious disease is introduced in a population, often no one else is infected. And in fact, for COVID-19, probably most exposures didn't lead to any onward transmission, but of course enough did that there was a global pandemic. So it's highly variable. And that makes models hard to validate. So I wanted to talk a bit about our approach to validation. What we couldn't do is look up, okay, what's the full distribution of outbreak sizes that have happened with measles? How many exposures go nowhere and how many cause 1 or 2 or 3 or 4 more cases? Because those data are just not available. But we aim to model realistic timing and behavior. So we want, the 10 days, the 4 days, the rash, the 15, so those parameters, and the 2 to 3 days to contact people and so on. We know that there are things that we know, right? We know that we don't have standing measles transmission in Canada now. So we know that even though we do have communities with 75 or 80% coverage, lots of them, we're not seeing consistent, long ongoing transmission of measles. So we know that whatever we're doing is enough to control outbreaks at those kinds of coverage. We know that outbreaks from the reports that we've read typically last about 60 to 70 days. So we wanted that timing to be realistic. And of course, once you start getting into 700 people, it will last longer. So we compared our timing and sizes to reported outbreaks where we could. And then, of course, we know that with higher vaccination coverage, exposures don't result in an outbreak. Transmission is not sustained. So those are some of the validation points that we had to confirm that the model is generating something that we think we can believe in. Here's an example. This is an example outbreak in a population that in total has 8,000 people, but here only a few dozen were in the outbreak, I guess 69 cases. It had the stronger public health interventions that I mentioned a couple of slides ago, and 75% vaccination coverage. And you can see kind of transmission for, okay, it's a bit over the 70 days, maybe 80 days here. It goes on. And then in comparison, just qualitatively to eyeball it, here's a reported case from Hall et al. In 2017 in Minnesota. There's an outbreak of 65 measles cases. And again, that lasts, let's see, March, April, that's about 60-ish days, and shows kind of a similar pattern of peaking out at about 4 or 5 cases in a given day, and then lots of single days and some gaps. This is the outbreak in which there were 8,000 people potentially exposed. And the interventions included case finding, isolation, and PEP in a partially vaccinated community. So kind of analogous. Okay, so now I'm going to get into the real results. And Kevin, feel free to interrupt me again. I see there are 5 things in the Q&A, but I'm not going to open it and look. Yeah, go ahead.
There's a few questions in the Q&A. They mostly revolve around the specific parameters. So maybe it might be worth quickly reviewing those parameters that went into the model. I think there's a fair bit of interest, and you have a slide for it too.
Yep, I do have this big table.
Yeah, so one of the specific questions was around the effectiveness of PEP.
Right. Yeah, this is something we're kind of in the process of changing. And at the end, I have kind of alternative parameters that I can show you that actually work out to be very similar outbreak patterns as the ones we see here. Here we basically model a sort of smaller fraction of people getting PEP, but then when they do, it's completely effective, rather than having a compartment where people have had PEP, but they're only half as infectious or a third as infectious as the rest. And it's these rates of the first thing is the strong interventions, and the second thing is the weaker interventions. And this is so sort of 15% of the population who, yeah, well, it's a rate of 0.15 per day in the population who is infected but not yet infectious, is leaving the state of sort of leaving the circulating, possible transmitting population at these rates. So they're going into a kind of quarantine class where they're not going to infect others. And that's these rates per day out of the infected pre-rash compartment. And then these rates are lower. That doesn't include PEP, and that's for the people who are in the susceptible compartment who are just asked to reduce contact or watch out for a rash. And if they start seeing any symptoms of anything, they since they've been exposed to measles, they should stay home and not infect others. So that's those rates per day in the simulations I'm going to show you. Yeah, go ahead, Kevin.
I think that's all. I think you can
Okay.
continue along.
Okay, great.
Thank you.
Yeah. All right, so that's the validation. So here's some example outbreaks in the larger population. And it's a bit of a complicated slide, but each panel with the colors is a different coverage. And that coverage, like I said, sort of overall, what's the fraction of the population that is immune to measles for whatever reason, whether it's because they had 1 dose or 2 doses or previous exposure. So in the 95 and 90% and really 85% coverage, nothing much happens here. In the 95 and 90, there's just one case. That's the index case. They fly in from Europe or wherever with measles, and okay, nobody gets infected. That's great. And then as the coverage goes down, you see that these particular example outbreaks continue, and when you get down to 75 or 70% coverage, they go on for a month or more. And of course, more people get infected. And then compared that over here to the weaker interventions, where we're not finding people as quickly. Again, with 90 or 95% coverage, nothing happens. But even with 80% coverage, that doesn't prevent this particular long outbreak of about 66 people. And then once you get down to 70% coverage, you start seeing a real, ongoing large scale transmission where a substantial fraction of the people who were susceptible, so 8,000 minus the 70% is a few thousand people, a substantial fraction of them end up getting measles. Whereas here it's still sort of controlled, but it does go on for a few months of kind of stuttering transmission. Okay, so that's some examples. Here are some example outbreaks in the smaller population, and these show the median and 95% range. Maybe it's the mean and 95% range, again, with coverage varying across the panels. And this is the number of rash, symptomatic with rash. So control is good, again, here with these strong interventions, but at 70 or 65 or 60%, you can still see kind of long stuttering transmission. Usually there aren't any new cases, but we were surprised by the fact that this can really kind of keep going for quite a long time. I would hope in practice that what would happen is, if you still saw this case or if you pop this one up, then interventions would be ramped up and the rest of it would be curtailed because of an enhanced public health response, even beyond the kind of defaults in the model. Okay, so then that, of course, those were all just kind of examples and a bit of summary. This is what we were really interested in, and in addition to the timing, was what are these sizes? So I'll take you through this a bit. This shows the distribution of simulated outbreak sizes by vaccine coverage. So vaccine coverage is increasing from the top to the bottom. Many exposures don't lead to outbreaks. In fact, with 95% of them, it was 95% coverage. All of the exposures in this simulation did not lead to outbreaks. But the chance of a sizable outbreak is high once we get into these lower vaccine coverage. And I've kind of used the phrase out of control and not out of control to describe this transition in the model between histograms that are all stacked up against 0. So it's mostly 0, but you can get up to, rare, but up to 100 people in an outbreak with 75% coverage. Versus when you get down to 60% coverage, you start, or 65, you start seeing this bump that starts moving out into larger population sizes. And that's where a substantial fraction of the people who are not immune at the start end up getting measles. Over here, it's still small, relatively small compared to the whole population. So well under 100 compared to the, I guess, in 1,000 people. With 75% coverage, there'd be 250 people who are not protected, and most of them don't get measles, whereas out here, a lot of them do. And that shows us how the sizes depend on the coverage and where, under these parameters, where that transition really happens between about, I guess, around 70% coverage. Okay, so measles can cause severe outcomes. And I haven't talked about this yet. The risks do vary by age quite a bit, but overall, if you just take the whole population, the CDC and a report that research that it's based on by Perry et al. report the following kind of rates, that hospitalization is required in around 1 in 5 cases. Measles also causes diarrhea, pneumonia, and otitis media, or ear infections, around 10% of the time. It rarely causes encephalitis or death, and that's around 1 in 1,000 or 1 to 3 per 1,000. So if you have an outbreak of 100 people, you don't expect anyone to die. It could happen, but you wouldn't, on average, you wouldn't expect it to happen. But you would expect, if you had 100 people, 20 hospitalizations. And of course, due to the infectiousness of measles, that can cause a real impact, not just because of the care of those individuals, but because of the infection control that you need to do. So we computed the expected numbers of these outcomes for median outbreak sizes in our model, with the caveat that if we don't know the age profile of the affected community, we of course can't use age specific rates. So that caveat is in the bottom here. And with the other caveat that we're assuming complete ascertainment. But of course, if some transmission is undetected, then these numbers would end up potentially lower, because undetected but immune people would be in the population. Okay, but with coverage, you might ask, well, how many hospitalizations would you expect to see? And you get up to the 3 to 50 range as you get into these lower vaccination coverage of 70 to 55%. And then you start expecting to maybe see 1 death or 1 case of encephalitis as you get into those lower ranges. Okay. So then we might ask, okay, well, we simulated these strong interventions, but we had to make these parameters, and they're a bit hard to relate to real public health action. So what happens if we change those parameters? And of course, if we have weaker interventions, we do get bigger and longer duration outbreaks. This is the same smaller population with weaker interventions. And you can see even with 75%, you now see kind of a bump at the start, going up to a few cases a day, and then going on for quite a bit longer into the hundreds of days. So. And again, I would hope that what would really happen here is that public health interventions would be ramped up in response, and these whole tails off into the months would be curtailed. But without that, ongoing transmission at very low levels can occur for quite a long time. And that's just because of the couple of weeks generation time. Here's the ridge outbreak size distribution plots for these weaker interventions. And you can see here that when we're not finding cases as quickly, and we're not able to offer PEP as often because we can find them, and people aren't isolating as quickly when they have their rash, maybe they're less aware that they need to do that. We start seeing this bump earlier at around 80% coverage. Because we're not seeing massive measles transmission in all the jurisdictions in Canada where we have 80% coverage, I think we are probably currently doing better than these weaker interventions. Or measles isn't, the infectivity is maybe a little bit less in Canada than in the sort of global are not estimates. But this is what would happen in this model if we had weaker public health interventions. We would start seeing these bigger outbreaks even at higher coverage. And you can see these kind of distributions now just sort of march across the page, and basically many or most of the people who are not immunized get measles. And that's what we'd expect if we didn't do much, right? Okay, Kevin, are there more questions that I should be pausing for?
There's more questions, but I think they can be addressed at the end of the talk, because they're not clarification questions necessarily.
Okay, super, thanks. Okay, so again, we looked at, with the caveat about age and not knowing the details of the affected communities, what would you expect to see in these weaker interventions? And now you start seeing, with these bigger median outbreak sizes, you do start seeing a substantial burden of hospitalization and a real risk that someone, I should say, these are not the risks that someone has encephalitis. This is the expected number of cases with encephalitis. So less than 1 or less than 1 death, but still, if the expected number is less than 1, you could easily see 1 or 2. And of course, that's, this is a preventable infectious disease. No one should be dying or hospitalized of measles. We have an effective vaccine. And I think even in the first few months of this year, 7 kids died in Europe from measles. So it is still happening, and there is for sure a risk. Okay, and we looked at our larger population and strong interventions, and these are harder to simulate because, of course, there's just more computational burden with 1,000 people. But here, even with 70% vaccination, there can still be hundreds of cases. They're still kind of controlled in the sense that the histogram is stacked up against the left, and most of the thousands who aren't protected are not infected. But that's a potentially high burden of cost for control for public health to be having 100 cases in total and having to do all the work of contact tracing and notification and so on. And then with lower coverage, there are even larger outbreaks, and I can show some of those at the end. And then the number of severe outcomes just scales accordingly proportional to size. As you know, as you get bigger, you just get more hospitalizations and so on that are expected. Okay, so I'm going to go into just a few of the limitations, and I'm well aware of the limitations of a modeling study. The model is simple. There are pros and cons of simple models. I like simple models. They require less data, and they're easier to understand and easier to work with. But it is simple, and for that reason, it doesn't have classrooms with social groups where the teachers and the custodians and the school are handled differently than the students, and the students have friendship groups and they have after school clubs. Like we didn't put all that in the model. And part of the reason for that is that information about those contact patterns during outbreaks is not available. We did look at some contact tracing data during COVID from Newfoundland and Labrador, and we found that the contact patterns actually changed during outbreaks and between different alert levels. So it's quite hard to incorporate these more subtle and nuanced contact patterns in a hypothetical community where, is it a jurisdiction in Alberta? Is it a school in Vancouver? Okay, so I've said already, it's challenging to translate interventions to model parameters. Past reported outbreaks are highly variable, as are simulated outbreaks. And of course, there's a newsworthiness factor when you look at reported outbreaks. With large outbreaks, maybe more likely to be written up than small outbreaks or exposures that go nowhere are not really written up for good reasons. But that makes it hard to validate models in this kind of highly variable space. We mostly modeled a kind of small, tight-knit community of 1,000 people with larger communities in the model too. Of course, when outbreaks are not controlled, not all stacked up against the left, their size just is much larger in larger populations. So in Lyon, France, there was a very large outbreak, I think 1,400. I'm not sure exactly. It's like out of my head at the moment what the number was. But there were many cases that took longer, and they also estimated that reporting was closer to 50%. So we've modeled very high ascertainment here, and our outbreak sizes include all the infections. But of course, if reporting is lower than that will complicate things. Okay, so I would say the outbreak sizes are inherently unpredictable. We can't predict what's going to happen when measles is introduced. Maybe nothing, maybe an outbreak. But we can characterize risks of larger outbreaks at different coverage levels, and we can characterize timing, and we can characterize the possible sizes that you might see and how likely they are. Okay, so conclusions. There are globally measles outbreaks and measles endemic transmission and rising transmission, and I think Canadian jurisdictions are likely to see introductions for that reason. People will travel, they will come back, and they may bring measles to us. Measles can spread in some Canadian settings due to lower coverage. When introductions do occur, outbreaks can reach dozens to hundreds of cases in some circumstances in under-vaccinated communities, and that can require a lot of work and effort and intervention on behalf of or on the part of public health. Transmission chains in this model can last for months at low levels, and if you combine that with the risk of underreporting, that presents the risk that outbreaks will be seen as over and the new settings might be exposed. So if these vulnerable pockets are linked to each other, outbreaks are unpredictable, but we can characterize risks and their sizes. Okay, so I want to thank especially the co-author of these slides, Jennifer McNichol, who is a student in my group who helped with a lot of this simulation. And then we have two other students who have helped with some of this research as well. And thanks to Ken Maude and Simon Fraser. So I'll leave it there and take questions. Actually, maybe I'll leave it here. Yep.
Yeah, so if you could, thanks for presenting, Caroline, Colleen, and if there's if anybody has questions, please continue to enter them in the Q&A. I will be we have about 15 minutes for the Q&A. I'd like to ask a question for first off. There's a bit of confusion about how we use modeling in public health. In your interview that was published in the CBC, on the CBC's website with Lauren Pelly, you say that models are more like headlights than crystal balls. Can you explain a little bit what you mean by that?
Yeah, thanks. I think it's a great question. And I think there is, people who are not as used to modeling will sometimes think models mean nothing. It's just a simulation in your computer. Or what does that mean? And sometimes they'll think, oh my God, like you've got time on there. That's like really a prediction that's showing us what's going to happen. And I think neither of those extremes are correct. The truth is somewhere in between. I think models are really helpful in synthesizing different pieces of information, putting them together into a story that we can tell, allowing us to explore scenarios and think quantitatively about what might happen. I think we use models all the time, like even when we use our intuition, if I think to myself, gosh, if I speed at 80 kilometers an hour down the street, Hastings Street towards SFU, I'm likely to get a speeding ticket. Like that's kind of a model. It's not a prediction. I can't predict like today is going to be the day I'm going to get my speeding ticket, but it is a model in my head of what is likely to happen if I take a certain action. And it's based on data, it's based on like my knowledge of the world. Like, oh, there's gonna speeding tickets happen. So I think models are more like headlights in that they can show us, they can illuminate the data we have around us and show us what is likely to be in our path. Models can be like headlights too. And I think this happened in COVID, where modeling was used to generate forecasts of, what does it look like if the doubling time is 10 days and we wait 40 days, we're actually going to double. Well, if we wait, like say 20 days, we'll double twice, right? So we'll have, if we had 300 today and we double that, we'll have 600. If we double that again, we'll have 1,200. We can generate those projections, and then we can use those projections and do something about it so that we don't see that. So if I have turn my headlights on and I get a better view of all the data around me and I think, oh, sheesh, there's a moose in the road, and I turn and I don't hit the moose, what I don't say is, oh my God, my model was wrong. Like it forecast that I was going to hit the moose and I didn't hit the moose. So it's wrong. So it's useless. I should turn the headlights off. That's of course poor logic. And I think that sometimes happened in the pandemic when, model predictions didn't come true, partly because the situation changed through human decision-making or otherwise. I would say models don't really make predictions, but they can make scenarios and projections. And so that, they're not crystal balls. They can't predict the future. I should say neither can your qualitative model or your infectious disease physician's intuition or a policymaker's intuition or my expert judgment, or like nobody has a crystal ball. I think models are a good way to quantitatively synthesize data and test our assumptions and generate scenarios. And I will stop taking all the question time to get on I'll get off my modeling soapbox now.
Thanks so much. So we have quite a few questions, so we'll try and make our way through some of these questions that were put up. So first off, did you and this is a great question for understanding the modeling a little bit more in depth. Did you or can you model an even weaker public health response, say 7 or more days to reach contacts due to reduced public health capacity, or no public health response at all?
Yeah, as it happens, I think this is an even weaker response here. Basically, if you don't do anything, what happens is almost everyone who was not exposed, who is not immune to measles at the start gets measles. So you can see here, like with 60% coverage, almost none of the outbreaks die out, and almost all of them land over here, where the remaining 350 people in the population, or almost 400, there were 400 susceptibles here, and almost all of them get measles. So this is basically what happens if you do nothing.
So there were actually a couple of those questions that were along those lines. So eventually, with low vaccine coverage and in the absence of public health interventions, everybody does end up getting measles.
Yeah, pretty much. I mean, here there would have been, so 65, so here, let's do 60. So there would have been 400 people who would have been susceptible, and of those 350 got measles. Here there would have been fewer susceptible and fewer got it, I guess. Oh, there would have been, yeah. Anyway, it's a little hard to reverse that here, but pretty much most of the people, not exactly all of them, but most of them get measles if there's no interventions in place to prevent it.
In your modeling, were there any worst case scenarios where an outbreak would linger beyond 12 months and fully threaten a region's elimination status?
That is a great question. And it's one we're going to look at. We haven't looked at it yet for the durations. Let me see. Here's one of the larger ones, and even these do, as one of the things that happens is as you have lower protection, actually it runs through the population really quickly. If it's close knit, and the longer durations tend to be where there's some control in place. You can see these like long durations here, but I didn't look at whether there are any over 12 months. I suspect not in these simulations, but I think if you had to have that, what would have to happen is, in this model, I think, is that you would have to have these kind of vulnerable pockets would have to be linked. And that you can tell a story where that would make sense, right? If it's a particular religious community or group that doesn't support vaccination, then of course people within that group may visit other members of that group in other geographic locations, and so you could imagine that seeding would take place.
Great. Here's another great question. The question is around whether you looked at alternate strategies, specifically a specific alternate strategy that is increasing vaccine coverage in the community, rather than putting most efforts into contact management, or you just, and that's part of it, or if you explore different percentages of those two strategies, like kind of combinations of those two strategies.
Right. Those are great questions. And the short answer is no. The longer answer is we do have an additional uptake of MMR in the people who are not yet infected with measles in this model, but we didn't look at trading off putting effort into that versus putting effort into the others, because I don't really have a great way. I mean, if it's something that public health is interested in, it would be interesting to explore that, but I don't have a great way to kind of compare those efforts. Like, what are the different costs of, and what's the impact? For the rate of additional MMR uptake during an outbreak, we did use data from BC that Fraser Health reported in that 2014, I think, outbreak, some numbers about how many more MMR doses they were giving out, and how they did it. So we did put that in, but we didn't trade off the relative effort.
Okay, here's another question. Do we know anything, do we know anything about the effect of A's structure in the result? I know you didn't model that explicitly, but maybe you can kind of conjecture
Yeah.
how it might or might not change things.
Yeah, I think what it would do is decrease the transmission parameter a bit. So instead of everybody in the network potentially being exposed at the same time, I think it would slow the rate of transmission, because contacts are more restricted if there's age structure, so you're not equally infecting anyone in the population. So I think it would slow things down and maybe reduce the R. That said, R naught for measles, of 15 may already take that into account. So yeah, I'm not completely sure, but I think adding more population structure would probably take, if you imagine one of these bumps, kind of flatten it a little. Remember the flattening the curve, kind of stretch it out a little bit.
There's a question. I think we're kind of outside of the realm of strict modeling questions. There's one question about looking at how you looked at your assumptions about vaccine efficacy, and whether those assumptions around vaccine efficacy take into consideration the fact that we're kind of in this elimination era, and whether we might see some waning of vaccine efficacy with age. There's some studies that show a little bit of a certain amount of waning of vaccine efficacy, and how that, I guess, might impact your results.
Yeah.
And there's a comment, and there's a specific comment that I'd like to within this question that I'd like to address, which is, in the recent PHO report, there's cases of measles that are double. There's 3 cases of measles that are double vaccinated. It's fairly normal to see double vaccinated cases. It'll be indicative of the fact that we actually have a high vaccination rate. There's a good chance that you'll end up with cases that are double vaccinated, even with a highly effective vaccine. So just to preempt full-on fear mongering.
Yeah, absolutely. I think it's so important, especially when we talk to the public, to not emphasize breakthrough infections and risk undermining people's trust in, like, this is a 95% effective vaccine. It is really, really effective. I know there are concerns about waning, and I think that's maybe an issue. I don't think it's as much an issue as jurisdictions with a 40% coverage rate in kids. So I do think it's an issue, but I certainly wouldn't imagine that the people in my age group should be rushing out to get a third MMR dose. That we're not where the transmission is likely to be in that waning now, I think. In our model, basically we just look at coverage. So however that 70% is achieved, maybe a few of those susceptible people are actually people who are doubly vaccinated, but they've waned. But again, without knowing, like, if we're just kind of thinking of a hypothetical vulnerable pocket and we don't know if they're 5-year-olds or 50-year-olds, the impact of waning is just going to be so different in those two populations, with the 5-year-olds not having waned and the 50-year-olds or the 70-year-olds maybe having waned. So a long-term care setting might be that's much more of a risk, because we don't really know what the 80 to 90s risk is after MMR, or I guess people in their 70s who maybe had, I don't have the ages right in my head exactly, but here we've just looked at coverage. However that 75% is achieved, 75% of the people are immune, whether that's really 80%, but with some 5% of those or a few percent of those may be at risk of breakthrough. If you're in a population that has 90% of the people are vaccinated and you do see transmission, you will see some breakthroughs, and they could even be in large enough numbers, 5, 10, 3 cases, to kind of raise eyebrows in the public. But of course, if you have 10 times as many people in the vaccinated group, just the sheer numbers will, even if they're at much vastly lower risk, that you will see some. There is data about severity and I think viral load. There were CT values, and the viral loads are lower. So it's not, from that one paper, at least I can find the link if people are interested. Doesn't look like it's as much of a risk for transmission. So that's another reason for, in these outbreaks, mild cases that don't transmit onwards won't be drivers of onward transmission. They won't change the outbreak sizes in these pictures.
Okay, thanks so much, Caroline. So with that, I'm going to wrap things up. I really want to thank uh, you for coming and presenting to us today. I think this is really an important perspective on measles transmission, and um, I just want to, I'll now go through a few kind of little closing statements. Um, as an attendee, you can expect to receive a brief, anonymous PHO round survey for today's session. Our comms team would really appreciate it if you could provide some feedback, and because it could really help us improve our programming. And access to past PHO presentations can be viewed online on the PHO website. So you can head to the education and events section where you'll find information on our past and future presentations. So thanks everyone, and have a great day.